Hi, this is Brian Kim. I'm going to share with you this case of a patient who was referred after a complicated cataract surgery. Apparently, this patient had cataract surgery and then developed IFIS and then had a Malyugin ring placed, and somewhere in that process developed, it sounds like maybe a suprachoroidal hemorrhage or something unusual, but there was vitreous loss. Essentially, the patient was left aphakic and now has a superior iris defect. And you're going to see how I deal with the iris defect with a fourth row pupilloplasty. And then, interestingly enough, as I'm doing the case, I'm developing a lot of subconjunctival fluid dissection and chemosis. And you're going to see how I handle this chemosis in the context of trying to execute the Yamane technique and how I'm able to place the needles through the conch, through the sclera, and making sure I get an adequate scleral shelf to execute the technique properly. So you can see this is a patient. You can see the superior iris defect, or at least retraction of the iris into the superior wound in this case. You can see there's even some vitreous strands coming to the wound. And this patient's fully aware of his visual limitations due to the complication in the past. But again, the patient is here for a secondary lens, and I'll also fix the pupil while I'm there. Best corrected visual acuity in this patient's around 20/70. And as you can see here, I'm trying to dry the surface of the eye as much as I can with the Weck-Cel sponge. And then using the tip of a 27 gauge cannula, I mark the tip, and then I'm inking the limbus on the right side, and then using that cannula, finding 180 degrees apart on the other side, and I'm inking the limbus on the other side, again, 180 degrees apart. Again, making sure that the surface is nice and dry, and the Weck-Cel sponge is really the best sponge to do this with. And this is a fixed caliper. I'm going to indent the sclera 2.5 millimeters posterior to that limbal mark, and then 2 millimeters adjacent to that mark. And I'll be able to apply the ink over the scleral indentation. And by inking the tip of the cannula, it's just a very nice, small, discreet, and precise way to mark the conjunctiva. And you can see I'm in low mag. I like to do these cases in lower mag, and I'm sitting superior temporal. Perform the same maneuver, indenting the sclera 2.5 millimeters posterior to the limbus, and then 2 millimeters adjacent in similar fashion. Again, drying the surface, and then I'll ink those indentations. Again, you want to mark and align with the eye in the neutral position, meaning the eye is not being torqued left or right or up and down. Go ahead and mark for the trocar, and I switch from the Weck-Cel to the cotton tip because this is a much better tool to manipulate the eye, not the Weck-Cel sponge. So I stab into the conch and sclera, and I tunnel about 2 to 3 millimeters, and then I dive down perpendicular, and then I pull the trocar needle out. You can see the way the trocar cannula is sitting a little bit sideways, which means this is most likely going to be a self-sealing incision. I make my incision on the left side and then the right side. And then I'm going to hold the eye because this patient really has a deep set eye, so it's a little bit of a challenge. So I'm using forceps to turn the eye so I can get a nice flat approach for my contralateral limbal incision. And I'm going to use that incision to externalize the leading haptic. I make another incision on the left side and then inject some intracameral epinephrine and then some dispersive viscoelastic. And I'm going to place the 22 gauge thin-walled AC maintainer through that inferotemporal incision. I go in with the vitrector, start to perform some vitrectomy because I do see some vitreous strands to the wound. You can tell that the surgeon must have been in a rush to finish the case and not put a lens in. You can still see there's vitreous to the wound. You can see there's focal retraction and fibrosis of the wound. I switch to the trocar cannula and I would go ahead and do some pars plana vitrectomy. Once I feel like it's cleaned up, I go ahead and bend my needles. This is the 25 gauge needle. I'm going to have the needle make sure the bevel is facing to the right. This is the right side needle. I'm bending about 9 millimeters from the tip. Make sure the bevel is facing towards me. This is the right side needle. You want to make sure the needles are mounted on a syringe full of BSS to ensure there's no bubbles. This is the left side needle. I bend it at the hub, making sure the bevel is facing away from me. Push some more dispersive viscoelastic to fill the chamber, and then I make my main incision. This is a 3 millimeter blade, and I make sure that I'm 90 degrees across from each of the marks and 180 degrees away from the contralateral limbal incision. Placing some viscoelastic into the chamber of the cartridge, and then putting the sensor lens, making sure it's seated deep before I fold the wings. Make sure the optic is seated, and as I bend the wings, you want to make sure the leading haptic comes out straight through the barrel and the trailing haptic exit from the back. Place the cartridge into the injector, making sure I slide it all the way forward. You want to make sure that your trailing haptic is sitting up and away from the barrel. So you see it's on top of the barrel. I push the plunger forward and then it goes in. Okay, I'm just recentering myself. Irrigate the surface of the eye. Place the 25 gauge needle contra-incisionally. I'm placing the injector through the main incision. Turning the bevel to the left. My assistant is delivering the lens. Once the leading haptic comes out, I dock the haptic on the bevel of the needle. I ask her to advance the lens some more. As the lens comes forward, more of that leading haptic goes into the needle. I pull the needle out and it comes right out. I take over and deliver the optic, making sure it comes out properly, and then deliver the trailing haptic out of the eye facing to the right. Inject some dispersive viscoelastic to coat the cornea and push the optic back. But look here, there's a lot of chemosis, and there must be some fluid dissection coming from my AC maintainer, and so that's mistake number one. I should have made my AC maintainer incision away from the conj. Now I'm having conjunctival ballooning. So what am I going to do? So the key is to turn off infusion. I filled up the eye with fluid. Turn off infusion, and I'm compressing the conjunctiva to the sclera. Once I've flattened the conjunctiva, now it's not ballooned. I don't turn on the water. I'm holding the eye, I'm stabbing the conj and sclera, and then I'm flattening it out. I'm tunneling 2 millimeters, and then I dive down. And so that's how I dealt with that. Despite the chemosis, I flattened the conj, made sure I had good visualization of the sclera, turn infusion off, stab through the conj, stab through the sclera, making sure I'm flat, tunneling 2 millimeters, and then I dove down. And then I turn on infusion, making sure the eye is nice and firm. I'm grasping the trailing haptic with smooth forceps, microforceps. And you can see how easy my access is because the leading haptic is outside the eye. I'm able to dock the haptic on the bevel of the needle, flatten it out, and then it goes right in. disengaging the needle from the syringe with some hemostats. Laying that right side needle down. And then I noticed something. I noticed that the needle is actually caught up into some thick vitreous strands. Sometimes when the vitreous has been sitting there for a while, it becomes kind of opaque and stiff. And some of those strands are caught up in my needle and it's kind of wrapped around the needle haptic complex. So here I'm just trying to use a vitrector to try to cut that. And it really didn't work very well. I'm using my right hand to hold the needle. I'm holding it up so I can see the actual fibers. And then I did the vitrectomy with the left hand. It didn't really work. So then I switched to scissors. And then using the micro scissors, I was able to cut those strands off of the needle haptic complex. And then I was good to go. And so every case is a little bit of a learning case, a different case. And you just have to adapt in the moment and utilize the fundamental skills that you know how to use and adapt to the situation. Go ahead and internalize the leading haptic. And then I'm holding the eye from the contralateral incision. And because of the push-pull forces, I think it's better to hold the eye from the other side. So I go ahead and turn on infusion, make the eye firm. I stab through the conj and sclera at the first mark, tunnel very flat, going 2 millimeters. I can feel the resistance. I'm tunneling 2 millimeters, and then I dive down. And throughout that maneuver, I made sure the eye was nice and firm. When you have a firm globe, you can more easily control when you're trying to tunnel the needle through the sclera. So you can see when you're dealing with the leading haptic, it's so much easier. Your access and view is so much better. I'm able to grasp the haptic perpendicular, dock the haptic on the bevel needle, flatten it out, and it goes right in. So the right side needle you pull away from you, the left side needle you pull towards you, and as you pull the needle out, you grasp the haptic. And you can see there's a lot of water there, so I'm going to have to dry the eye. You want to dry in the area of the haptic first. And once it's nice and dry, you can try to cauterize the tip. If it's wet, you're not going to get an even cauterization of the tip of the haptic. So that's done. Go ahead and pull the right side needle. Again, you're pulling the needle away from you. I made sure that the forceps are ready to grasp the haptic. And as I pull it out, the haptic comes out. And I want to make sure that not too much of the haptic comes out. You want to dry the surface of the eye in the area of the haptic, and then go ahead and cauterize. Again, if it's wet, it's difficult to cauterize, so you want to first dry. Push the haptic into the sclera, reapproximating conjunctiva. And so far, so good. So despite the conjunctival chemosis, again, I was able to flatten the conjunctiva in the area of chemosis, make sure I turn off the infusion. And then with infusion off, I was able to basically stab through the conj and sclera and tunnel 2 millimeters in order to execute the scleral fixation. And so that's the pearl in that situation. I'm using a canyo to sweep that main incision, which had the vitreous coming to the wound. I'm trying to do some localized vitrectomy in the area of that incision. And once I'm confident that it's clear of any vitreous, I'm going to go ahead and place the tenoproline suture on a CIF4 needle, placing it through that paracentesis incision. And then I'm going to make a new incision here, which is going to be a better access point when I try to externalize that needle. So I make that incision on the left side, and with microforceps, I gently grasp the edge of the pupil, stab with the needle, and then push through on the other side. And then I'm going to use a cannula so I can actually pass the cannula through the incision, clear the incision so I don't grab any corneal fibers, and then place the tip of the needle into the lumen of that cannula. And then I'll be able to pull the cannula out. And when I pull the cannula out, the tip of the needle will be out of the incision. And then I'll be able to pull the needle all the way out. And then I'll have suture fixation on either side of that iris so I can do the pupilloplasty. And so now I have the Prolene suture secured on either side. This is the bond hook. I'm going to go through that left side incision in the same incision where that suture is coming out of on the left side. I'm grasping the suture on the right side, emanating from that right side incision with the bond hook, and pull it out, and I'm creating a loop. Again, externalizing it on the left side. And again, this is a Siepser sliding knot technique, but utilizing fourth row pupilloplasty in this context. And so that sliding knot will go in, but because I've done 4 throws, I don't need to make any more throws after this. I'm able to just lock it in, taking advantage of the fourth row pupilloplasty concept. Then I start to perform the 4 throws. So you see 1, and then 2, and then 3, and then 4, and that's the last one. And then I pull from the other side, and as I pull, the loop will slide into the eye. And then it'll cinch down the pupil, and you'll have a more round pupil. And then using micro scissors to cut the suture at the pupillary edge. And then this is a surgical PI. I switched to the PI setting. I'm going through a contralateral incision and making the PI temporal now. Turn the port down, making sure I don't go all the way to the periphery to the angle, which can cause a ciliary body hemorrhage. Once the PI is done, I turn the water off. I place my tenonylon suture. I put some Kenalog here at the very end just to make sure there's no vitreous. Again, in the very beginning, it was pretty obvious where the vitreous was, and I was able to remove it. And that's why I really didn't use it at the very beginning of the case. But now that we're completely done, you just want to do this as, again, a reassurance that there's no vitreous in the anterior chamber. And plus, having that little bit of steroids helpful to quiet down the eye as well. Again, no vitreous in the anterior chamber, and then going pars plana and doing a little bit more vitrectomy just to make sure as well. And this is really the end of the case. And so you saw that this patient had iris trauma, vitreous to the wound, left aphakic. The patient had obviously traumatic and complicated cataract surgery. Based upon what the patient tells me, it sounds like the patient maybe had a suprachoroidal hemorrhage or something like that. And when I looked at the patient's retina, you do see this unusual area superiorly where there's, again, like a deep kind of elevation in that one localized area superiorly. And so this patient's best corrected vision is around 20/70. We went ahead and did the Yamane, but again, because of the AC maintainer being a little bit too peripheral, it caused significant fluid dissection under the conj. And so on the right side, I had some trouble because there was conjunctival ballooning. And so what did I do? Well, you can cut down the conj. Remember that, everyone. If you want to cut down the conj, that's perfectly fine. I think that's totally okay. Of course, if you do that, you'll have to suture things closed. But in my case, I went ahead and massaged the conj down, made sure that the fluid was expressed, and I made sure that the eye was firm before I did that. And then by holding the eye and making sure that I stabbed with the needle through the conj and through the sclera, even though there was no active infusion, because the eye was firm, I was able to control the eye, stab, flatten out, tunnel through the sclera 2 millimeters, and dive down. Again, all without infusion being on. And so again, it goes to show you can execute the scleral fixation and tunneling of the needle through the sclera even though you don't have active infusion. As long as the eye is firm, and you're able to, again, express and squeeze out that fluid underneath the conjunctiva, I was able to still execute it properly. And of course, all of this is made easier because I externalize the leading haptic through a contralateral limbal incision with a 25 gauge needle passive docking technique. The left side cannulation of the needle is so easy because the action is away from me, and I was able to bend the needle in such a way that I flatten the haptic on the bevel needle, docking it, straightening it out, and then executing it. And so this patient did quite well, very happy after surgery. Obviously, the pupilloplasty has been around now for a while, and Agarwal's team has done a great job in teaching all of us that, and that went super easy. Normally, with the Seepster sliding knot technique, you have to do so many throws, and it just takes a lot of time, very time consuming, but the forward throw is really so elegant, so easy to do. I was able to close that pupil as well, and the patient was relieved and really happy that we were able to place the lens in this setting, a very complex cataract situation. So I hope this was helpful to you, and I thank you for your attention.